board question. I think it was a proposed board question. So that would mean like, all right, so if you've got, think along the lines of that active and passive insufficiency. So if you've got, my knee is flexed and my hamstring is in a shortened position, correct? Okay, so think of that as point A, and then if we have it completely elongated, point B, and then the distance between point A and point B would be functional excursion. I've never seen it used in a chart or anything like that, but again, it is a term, so I wanted to at least bring that to your attention, so if you saw it, you didn't freak out. Do we really need to go over active and passive insufficiency again? No? Well, we will anyway. Active, muscle reaches a point where, because it's a little bit different slant on it, where it cannot shorten any further, occurring to the agonist, right? So if you want to look at it that way, it's a little bit different slant. So the biceps for elbow flexion, all right? We can't go any further, right? It's in the shortened position. Can't go any further with maximum elbow flexion. And it could be with supination and shoulder flexion as well. So if you really want to incorporate all three of those muscle actions, that's going to shorten it to the fullest extent, as opposed to passive insufficiency, when a muscle cannot be elongated any further without damage to muscle fibers occurring to the antagonist. So if we are in that same position, what's going to be passively insufficient?
Triceps.
The triceps. Okay. So look at the antagonist there. In that example. Passive range. Passive range is going to be produced by some type of external force, mechanical, manual. Mostly what we're going to see is manual from what we do. Active assisted. We'll practice some of that today. Combination of external and some type of muscular contraction. In the course of active ranges, there's going to be contraction of the muscles. Indications for passive range. Acute inflamed tissue. Why would we want to passively range acute inflamed tissue? That seems ridiculous. Why would we do that? As opposed to active or active assisted.
Because it's painful.
Yeah, so if you've got tissue that's actively inflamed, if we ask it to contract, it's probably going to cause more pain, more inhibition. You guys are going to learn a lot about that kind of thing. Probably cause more of that vicious cycle, right? The more we move it, the more it hurts, so therefore we don't want to move it. So we got to move it. We know that. We know that healing's got to take place. So we want to move this tissue, so passive range is a good way to do that. Post-operative care. So give me an example of when that's going to be the thing to do.
You may have a patient who doesn't believe they can move as much as they can. So you'll probably have to passively move them.
That's very much true. And a lot of times you will passively move a joint just to kind of show somebody, hey, this can be moved. But there's going to be a lot of times post-operatively when we get somebody who's had a repair, okay? Whether that's a rotator cuff repair, ACL repair, whatever that might be. But those are two different things too. You've got a ligament, and then you've got contractile tissue. So which one of those two, ACL or the rotator cuff, is going to be indicated for passive range? Rotator cuff, why?
Because you're trying to because those muscles are going to be fresh. So doing that passive is just going to help strengthen that.
You are on it. We don't say strengthen though. Can't go there yet. So we take a rotator cuff, okay, and it's repaired. And I say we, orthopedic surgeon, is going to take the end of that and suture it to the bone through an anchor or through buttons or staples, whatever they're going to do it. They're going to put it to the bone, okay? Do we need to start actively using that muscle? Because that's what's going to happen right there. Right? So passive range for rotator cuff repair is super appropriate for probably the first 6 weeks. Why is it not indicated for ACL?
Because it's a ligament?
Yeah, because
It's not contractile.
it's just aluminum.
It's, we put a new ACL in there, very similar. We're gonna put a bone plug in here, screw in here, here's your ACL, okay? But because it doesn't contract, we're not worried about that. We still need to get things moving. We need blood flow to occur there, right? So we want active movement with that. Now, we don't want them doing crazy things that are gonna disrupt this graft. And we'll beat this horse to death in this semester. But we've got to understand the differences between passive range of postoperative contractile tissue versus postoperative connective tissue, okay? Does that make sense? Because if we don't get that, we don't need to keep going further right now. We've got to understand that, okay? Patients unable or not supposed to actively move a segment. Okay, so there's gonna be times, you guys have talked about Guillain-Barré, right? Somebody's in the state of with Guillain-Barré, and a lot of times they can't do anything but move their eyelids, all right? So if they lay in that bed for that long period of time and do not move, what's gonna happen to them? Stiffen up dramatically. You're gonna get contractures everywhere. So that might be your job to come in there and move every single joint passively. Seen it done. I've never personally had to do that, but I know that that's been ordered several times for our students and people that I've worked with. Can you imagine how long it takes to move every single joint in your body? So, goals of passive range: maintain joint connective tissue mobility. All these are just common sense. Minimize effects of form of contractures. Maintain elasticity. Assist in circulation, vascular dynamics, which is healing, right? Synovial movement, that's a good thing. Decrease or inhibit pain. How's that possible? Is a distraction force a kind of passive range of motion?
Yeah.
Maybe.
Yeah.
You can certainly distract them and move. That's great for that. Feels wonderful to them. They'll love that. Assisting with the healing process because of these other things with circulation. Help maintain patients' awareness of movement. Someone lays in the bed and doesn't do anything, they lose it. They lose it up here too, that they don't know that they can move a joint. So we've got to help facilitate that as well. Passive range is a very skilled thing. We're gonna have to work on that, okay? And again, in here, you've got a bunch of healthy people. But you get in the clinic, you're gonna have people who are in pain. And when they are in pain, they're gonna resist you. They're not gonna let you move it. So you're gonna have to use your facilitatory techniques. Hey, let me have this. Let me distract it. It's gonna feel better. Now we can move it, okay? You gotta talk them through that. And it's even more important when we're talking about passive range that you tell them what you're doing. Because again, these people come out of surgery and they're in a sling or they're in a brace or whatever. You take that brace off and you just start moving this thing all over the place, they're gonna hit you with the other limb, okay? You got to be able to prep them. So talking through things is gonna be really important as well. Other uses, certainly in examination, demos, prep for stretch, whatever there. Limitations may be difficult in a conscious patient. That's what I was just saying. If you've got somebody who is in pain, there's gonna be some limitation there, okay? That's your job to get, if you've got a fresh rotator cuff and you've got somebody just sit there with no external rotation, and they sit here for a long period of time, and they love that sling, people. Let me tell you how much they love that sling, because it sits here and it feels good, it's not moving, it doesn't hurt. But that's not your job. Your job is to passively get this thing moving. Pretty much all planes, right? But you better prep them. You better prep them. It does not prevent atrophy. Why? Non-contractile, correct. It's totally passive. Doesn't increase strength or endurance for the same reasons. Limited effect on circulation compared to active motion. Again, because it's not contracting, you're gonna get less of that fluid exchange. There is some fluid exchange, especially with the synovium, but not nearly as much as active range. All right, so when are we going to actively or active assistively range somebody? When they're able to contract, when they're weak, mobilized segments below and above an immobilized region. Okay, now think about that one for a minute. Let's go back to our rotator cuff for a second. Somebody's had a repair, and we have said, the protocol says we've got passive range of motion only to the shoulder for the next 6 weeks. Okay? Only passive. Does that mean their elbow can't move? Nope. Better be getting that going. Nothing wrong with that bicep. May not feel great, because they may have swelling that comes down, ecchymosis, swelling, tenderness, all that kind of stuff. But this better get moving. That's the joint below. What's the joint above? The shoulder. Yep. That neck needs to be moving. That trap doesn't want to get tight. Hey, you got somebody that's in a sling like this. You think that trap is not going to get rock hard? That's when you use your modalities, use your soft tissue work. But you get that neck moving as well. Or nose, they don't need a stiff neck to go with a stiff shoulder. Right? Aerobic conditioning, we'll talk about that until we're blue in the face. Relieve stress from sustained postures. Look at Karcher right now. A lovely posture right there. Don't move. What's going to get tight on him right now?
Pec.
Pec is just shrinking by the minute. What else? His traps are holding his head up, which is forward. Yep.
His biceps.
All that stuff, okay?
Extensors.
So relieving stress, we get him just to move around, say, hey, do some shoulder shrugs, scapular retraction, cervical retraction. If he does that a few minutes of every hour, he's gonna be okay. You're gonna be all right. And you're young too. Goals, same as passive, plus elasticity and contractility is enhanced. Sensory feedback. What's that called? Sensory feedback from contracting muscles.
A-finger?
Anybody have an idea? Sensory feedback from contracting muscles. So if you think about it from a joint perspective, that's proprioception, right? Knowing where your joints are in space and all that kind of thing. Kinesthetic awareness is what it's called for muscles, okay? Same type of thing. Providing a stimulus for bone and tissue integrity. How's that the case? Does bone get stressed when we move joints?
Wolf's
Yeah,
Law,
absolutely.
right?
Absolutely. Same with joints. Our connective tissue gets stressed. That's a good thing. We just don't want to overstress it, like we talked about Friday. Increasing circulation, preventing thrombus. You guys know all about that. Develop coordination and motor skills for functional activities. Boy, that's when it gets fun in here, is when we start talking about coordination, high-level functional activity. Boy, I hope you guys are ready this summer. We're going to be doing some athletic endeavors. Limitations. Active range of motion really doesn't maintain or increase strength in strong muscles because we're not asking it to resist anything other than the weight of the limb. And develop skill, okay? We've got to do other things to do that. So precautions and contraindications, you guys know by now that board questions love precautions and indications. So anything here that jumps out at you that would be out of the ordinary? Not really. Passive range of motion initiated major joints in active range to ankles, feet to minimize venous stasis and thrombus. I think you guys know that. After MI, cabbage surgery, angioplasty, active range of motion of upper extremities and limited walking are usually tolerated under careful monitoring of symptoms. We'll talk much more about that at the end of the semester when we get to cardio pump. But yes, walking's really good for just about anything, okay? One of my favorite doctors in the world who, if something happened to my shoulder, I would go fly across the country to go see him. His big thing was get people out of the damn, he would cuss it all the time, get them out of the damn sling and let them walk. He says, because look at this. This is just a nice little pendulum movement here when they're walking. Great for blood flow to the shoulder. Great for blood flow. He was a big believer in that. Get them out and get them walking. Oh, applying these techniques. Okay, again, we have got to communicate, all right? And I know that's the thing that, one of the things that you guys are really apprehensive about, and well, you should be. But that's what you're gonna get to start practicing every Friday now, from here on out. Let them know what you are planning on doing, okay? Freedom, we gotta make sure it's free to move. We don't want restrictive clothing, whatever, but we gotta drape them appropriately as well, okay? That goes without saying, but again, that is much harder than it sounds. You're gonna have some people wear some really crazy get-ups to even outpatient therapy. I'll just leave it at that. Please straight. Oh goodness. Positioning, make sure they're comfortable. You know, we've got these tables. If I am working on someone's shoulder, I can promise you they're gonna love you if you can put them in this position as opposed to laying them flat. Okay, so make sure you take advantage of these things. And if you don't have tables that do that, you've got wedges that can do that, pillows that can do that, bolsters that can do that, right? Think about it from their perspective. They are hurting, they are vulnerable. What can you do for them? We are the ultimate customer service profession, okay? Mechanics, watch it for yourself too, okay? High-low tables are high-low tables for a reason. Make sure you use them. Oh, application of techniques, grasp. All right, so I think I've told you guys this before. Nothing says I'm a student and don't know what I'm doing more than someone who is like this. Oh gosh. Oh. Have a nice firm grip on them, okay? And communicate with them. Say, okay, hey, I'm gonna distract this. Does that feel better? And they're gonna say, yeah. Okay, but I've got a good firm grasp on them. I have control of their arm. Because a lot of times they're not gonna be one to move this thing at all. They have to surrender it to you. If you're wishy-washy and, ooh, I don't know if I should touch here, they're gonna sense that, they're gonna be guarded the whole time, and then they're gonna hurt more. So they're not gonna trust you if that's the case. So a good firm grasp. Movement, again, there's gonna be certain times when you can't go through a full range. I try to communicate with them. If I'm doing passive range and I say, okay, I gotta get you to, it doesn't mean anything to me to say, hey, I gotta get you to about 45 degrees of external rotation per this protocol, blah, blah, blah. But I can tell them, hey, I gotta get your arm to about here. So we're gonna work over the next 20 minutes or so, and we're gonna get there. Because you're gonna start here, it's gonna feel like you're hitting a brick wall. But you're gonna do some joint mobs, you're gonna do some passive range, you're gonna do some distraction, all those things, and eventually contract, relax. We'll talk about that today. It's gonna get there. But it's good to give them an idea, a blueprint of what you're trying to do. Perform motions smoothly and rhythmically, depending on the objectives, conditions, and response. Yeah, again, if you are rigid, if you are juddering, and you'll be nervous, but if they sense that, they're not gonna trust you. They're not gonna let you have that limb. So you got to get confident with it. That's why we're here. Force of the movement provided by the therapist. Oh, that's just the wrong definition. Application. I think that link is no longer good. I just checked it. It was good last year. Okay, self-assisted range of motion. which is usually active assisted range of motion. You guys have seen some of this, right? We have a all right. We can help range. This is my involved side. It's my good side here. We can do this. Active assisted. That kind of thing. All right. Wall climbing, finger ladder. You guys have seen those before. Just walking the wall. Ball rolling, overhead pulleys. We'll have to bring those out in a little bit. A powder board. Everybody seen that before in a clinic? Just decreases friction, so it allows them to scoot. Okay, they can take their arm. A lot of times their leg. They can't. They don't have any, not any muscles, but very limited ability to move the limb. Decreases the friction. Reciprocal exercise unit. One of my favorite things to stretch. We don't really have a lat pull down in here, but a lot of times, everybody's seen the lat bar, right? To stretch the lat, everybody thinks, well, you're gonna sit here and just do lots of lat pull down, pull up type of motion to build the strength of the lats. Well, that's the best way to stretch the lats too, is get them in this position, put a ton of weight on that machine, and then just start tipping this thing. And you can rotate it, get an unbelievable stretch through here. It's a great way to stretch. So using exercise equipment to help you range somebody can be very effective as well. We'll practice some of these things. Let's just do that now. Let's get some stuff out here. Pretty straight.
More stuff in the way.
All right, gather around. All right. Famous pulley unit. Got somebody post-operative rotator cuff. Is this a passive exercise?
Yes.
No? You're actively assisted.
So, the EMG studies that they've done, okay, the literature says that this elicits about a 15% contraction of the involved side. So it's not completely passive. It's pretty close. Yeah. Okay. What we've got to do is teach them how to make this passive. Because what you don't want them to do is do this. Okay? We want them to put their hand in here, make it very limp. Okay? And if we want to stay in this straight sagittal plane flexion, this is the motion. Okay? Now, they may not get to here the first day you're doing it. But do we want to just go back and forth like this? No. Get it up, hold it 15, 20 seconds, then let it down. Now, what am I letting it down? Am I pulling it down with this side, or am I letting it down with this? That's the key. Okay. Because when's it gonna hurt more? When they do a concentric or an eccentric?
Eccentric.
You don't know how bad it hurts and how much they have to work to eccentrically load this thing. Especially if they've got anchors and screws in here. So, I'm gonna leave this here. We got another one as well. Make sure you come over and get a feel for this. Right? And what I always tell them to do is I say, okay, I want your back against the wall. I want you to start in this plane. Okay? You're gonna hold that at in range, let's say I can get to here. 15 to 20 seconds. Now they're never gonna last that long. So you need to sit there and count for them so they understand. Because you tell them 15 to 20 seconds, they're gonna do about 6 or 7, and then they're gonna want it down. Because it hurts, it doesn't feel good, but they've gotta do it. So we're gonna start here. What I'll do is I'll bring them back down, and I'll say, okay, what I want you to do is take it out 2 inches. We're working into what plane now? Scapular plane, okay? This will be better, more likely than this. This gets a little more impingement. This feels pretty comfortable to people. Danielle's nodding her head because she's seen this a lot, right? Yeah. Now, what does it feel like when they're here?
They don't like it.
They don't like it. Abduction is the hardest. The arm is the furthest away from the body, okay? Hard for them to relax and do this. Really tough. So I always start in the front, work my way out this way. Does that make sense to everybody?
Do you work that full progression in one treatment?
Yep, usually, unless they're really struggling. If they're really struggling, I may just stay in scaption because they're just gonna feel good and I want them to at least have a success moment there.
So would you start in this point and then move them out?
I
Like,
tend
initially,
to, and I don't really know why, because I probably should start them here. But I tend to start them here and then work this
But
way.
if it's too much pain, would you just go ahead and?
You could put them in scaption and go from there, because I think that's gonna be the most comfortable plane, for the most part. There's exceptions, but. Alright. Now, what else can we do with this? Could we go into, what's this? Internal rotation, right? Also some extension. You gotta be a little careful with this one. You get a fresh shoulder, you don't want them jamming this up in here. That's gonna just impinge and get really sore really quickly. But I try to show it to them because I want them to know, hey, your arm does go back there. Eventually, you're gonna be able to control that. Patient, lay down. Yes.
Push away this way.
That's fine. External rotation, really, really important. I love straight cane. Golf club works really well with a club head. Right here, we've got her at about 30 degrees of abduction. Go ahead and grab that. And you just teach them this. Now, what are they gonna do? They're gonna do this. Is that the same? Yeah, that's not rotation. That's what? That's elbow extension, right? Body mechanics. Minus 10. What's that? High-low for a reason, correct?
I was 10, that's a fail practice.
Could be a fail. Good thing I passed. And never have to take another one. Can't be said for y'all.
Lucky you.
But look, we can do this too. We can go into abduction. And you know, look, I've got my hand on them, especially the first few times we're doing this. Because what are they gonna do the first time? They're gonna go up here and they go, ooh, that hurts. Yeah, they're fighting you the whole way. You gotta let them relax. You're taking it up this way. So this is a really good tool. So I'll use, again, straight cane, golf club, yardstick, broom handle, anything that's at least 2 feet long and doesn't give, right? You know, so a lot of times they'll say, can I use, gosh, what's something that bends? I can't, sorry. Flexion. questions?
So for this one, I see you're doing it with her, but would you take your hands off it?
I will eventually.
Will eventually.
Once they get a little confidence and I get some confidence in them that they're gonna do it the right way, that they're not just gonna slam
Yeah.
it, they're not, because they hurt. They're not gonna do that. But maybe you just sit here and just do like a little bench press thing. Seems like nothing, but ooh. You had shoulder surgery? Oh yeah, it's big. Tough. Anything else you've seen?
So about like we'll combo the press and the flexion because we've seen like with the reverse total they can't go automatically back. You have to press it
That's correct.
and then they
They've
can
gotta
go
engage,
back.
yeah.
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 So that's what we've just done.
There are times when I'll use this against a wall. That kind of thing. Or use a washcloth and have them wipe the wall down. The walk in the wall with the fingers. There's all kinds of little tricks out there. You'll see a lot of different things. Go ahead and stand up.
Wax on, wax off.
Wax on, wax off. That's what we're getting ready to do right here.
Hey.
Let's chin up stool. Have a seat. Get your left shoulder.
You're just
First
feeling
let her
right
sit
now.
on the stool.
I will let her sit on the stool because I'm right here. Now,
Safety.
we can lean forward and push this arm out. That turns into flexion, doesn't it? To some extent. Lean a little bit more. And if I lower the table, whoops, other way. Now push out. Flexion. Okay. If I turn her body, then we get a little bit of adduction. So this is definitely going to be more active assistive. Probably further along in the process, 4 to 6 weeks. Something like that. That's a good one. You start working on scapular retraction and stuff here. Can you pull your shoulder blade back for me? There you go. Good. Good. And then they realize, hey, this is connected to this. Amazing. The light bulb goes off. Yeah, exactly. All right, so we have another door somewhere we can put this. We can put it on the do not open door. Anyway, all right, back in seats. Thank you, babe. CPMs, everybody seen one of these before? These are mostly gonna be in the hospital, mostly with total joints, total hips, more total knees than anything. But you see what this contraption she's in here, and this is a hinge that will passively move this joint. Now, there are some doctors that do never order this at all. Couple reasons. Number one, the literature really doesn't support that it's that helpful. The limited research that's been done will say that it improves blood flow, it prevents contraction. That's common sense that it should do that, right? Because you're getting some movement there, you're getting some fluid exchange, you're not letting it get stiff. You can set the speed, you can set the range. It's a great device. But unfortunately, there hasn't been a whole lot of research out there that says this is actually what it does. So what does insurance say? No go. A lot of them, at least. But if you're fortunate enough to work with someone that has one of these, I think things are a little bit easier because you don't have to spend as much time doing passive range. Just the machine's doing it for you. You can put people into this up to 22 hours a day. They're sitting in the bed, they can't do anything else, the machine can move it for them. So my case study several years ago was a guy who had a total knee replacement. So I go in to do his therapy. This is acute care. I am wet behind the ears. I'm like, you guys starting on Friday? That was me. I go in to set this thing up on this guy. And again, it's a contraption. You can see all this stuff. Lines everywhere, and plugging stuff in, moving equipment. I'm putting this thing on this guy. Guy has a heart attack. Yeah. Acute MI. I'm ringing everything, and people are flying in here. Code blue. Because it's real. So guess who got to go to the ICU and set up the CPM with this guy's got like 14 different lines coming out of him? Yeah, because the doctor's worried about his damn knee. He's like, do not let that knee get stiff. I want that CPM in there. Yeah, I get to go into the ICU several times a day and check on this guy, and he's all hooked up. He's out. I mean, he's sedated, all this stuff. But yeah, we got his knee moving the whole time. It's a very interesting case study. I came back to school, presented the case, and they're like, you should present that at state conference. That's remarkable. I'm like, okay. Gives me shivers just thinking about it. Luckily, he was about 5'3". He was like the size of a jockey. Tiny man. Thank goodness. Benefits of the CPM, here's what it proposed to do. Again, prevents adhesions, contractures, stimulates healing, maybe. It enhances healing of incisions, maybe. Synovial lubrication, I would definitely say that that could be proven. Degrading effects of immobilization, perhaps. Quicker return of range of motion, I definitely could see that. And I do think it helps with post-operative pain because it's moving all the time. It doesn't have a chance to sit there and get stiff, okay? That's when people have more pain, is when they haven't used it and then they start to move it. Not a lot of fun. Has anybody seen this stuff, CPM before? Okay. Hopefully you get a chance to see that in an acute care setting. Guidelines applied immediately after surgery. I'm talking like an hour after surgery. The arc of motion, again, is adjustable and determined. The rate is adjustable. Duration on the machine. Doctor's gonna give you all that stuff. You're not gonna make a clinical decision on that. It'll be some type of protocol. PT is included during the off period, so if you take them out of the machine, that's when you go and do the therapy. Very portable, usually battery operated. Now, I don't say usually, but more times than not, they'll plug in. They can really take it anywhere. Take it home with them. Functional patterns. Is that a real functional pattern? It helps you go up, downstairs, squat, things like that. But this is talking more about functional things, you know, like eating, putting something up into a cupboard, getting dressed. These functional activities that require range of motion, obviously, every one of them does. All right. Why don't we take an 8-minute break and be here at 5 till. Everybody make sure you practice pulleys and all that kind of stuff, because that's what you're gonna get checked off on.